Thanks for listening to the Granite List.Live. Today's episode is brought to you by Connect Healthcare Collaboration, where benefits marketing meets clinical advocacy to drive effective employee engagement. This is the Granite List.Live, and I'm your host, Sally Pace. And today we are joined by Dr. Cristin Dickerson, who is the founder of Green Imaging. Dr. Dickerson, for context, can you give a little bit of just a brief overview of imaging as it relates to the health plan?
The cost of imaging is skyrocketing, much, much higher than the inflation we see with healthcare overall, which is skyrocketing. And there are several factors behind that. Number one is private equity acquisition of radiology groups, and another is trying to get to the plan beyond patient collection. So there's a lot going on there. There's also the radiologist shortage, and RVP is not working well with these private equity groups. So everybody's looking for direct contracting options and clean ones, frictionless ones. And I think, that's where we're really focused on being the leader, is providing that friction.
So let's dig into those trends a little bit more. Talk about the private equity aggregation.
I can talk about the trend a little bit more. I can say that when I have a friend who was looking, at what to do about his centers, he was struggling financially. He's got a number of imaging centers, great equipment, and was approached by an imaging chain. His EBITDA tripled based on their contracted rates versus his. So it is very, very attractive to independent centers to consolidate in that manner. Same for radiology practices. It's very hard to be an independent, very hard to get your own contracts as an independent. And the big private equity-backed groups have consolidation. They have leverage. They can get much better contracts. They're consolidating good old contracts and billing out under the best old price. And so we've seen the reimbursement rates for professional fees go up dramatically. Third is the radiologist shortage. 10 years ago, a Nobel Prize-winning physicist predicted that all radiologists would be obsolete within 10 years because of AI. That has not happened. And in fact, there's a radiologist shortage, and, he has retracted that, but it did a lot of damage to the profession. For a couple of years, all of the radiology residency open seats did not fill, whereas before it was one of the most competitive, residencies available. So a lot is happening in that consolidation space and, in that space of economic change. The other is, as we know, in Texas, 65% of Texans are not getting care or are delaying care because they can't afford it. And so access is a problem, and it's causing delays in care, and it's causing worsening, more expensive disease in the employer space. And so when in the setting of imaging, you can pay less for imaging when there are options for paying less for imaging. And an employer can afford to pay less. And with the gap between that and what they were paying in the claims data, they can provide it at zero out of pocket for employers and still save money. The current status of nobody doing anything and just watching Blue Cross Blue Shield's contracted rates go up and up and up, kind of makes no sense. And so direct contracting is getting a harder and harder look by larger and larger companies. And going back to the access problem, City of Plano in Texas, the head of their health plan was on a panel with me at Houston Business Coalition on Health. And Andrea said, we brought green imaging in to solve what we knew we had, a cost problem. And actually, we were solving an access problem as well. So our ability to get people the care that they need quickly and still save the employer money really behooves the employer. And in fact, if you look at the larger business purchasing coalitions, they're saying their employers are complaining that they're spending as much time on employee time away from work trying to navigate the health system as they are on the healthcare itself. And that just shouldn't be happening. There are entities out there that can assist with the access problem. And people want somebody assisting them, helping them, Sherpaing them when they are, under healthcare stress. And I would argue that anytime a person approaches us getting a testing exam, they're under healthcare stress. Even the day that you go get your screening mammogram is stressful. And so, everybody's in that scenario, and getting people the care they need is part of our promise, not just saving money. And then, moving to the saving money piece of it, I always argue that, yes, we are here to save money, but there's such a huge gap between what employers are paying in the claims data and what independent practices get paid by the major payers, that we can afford to pay them well and be their best client. And we want to be their best client. We want on Friday afternoon to keep patients out of the ER because we can get them a pulmonary CTA or a DVT study on Friday afternoon at one of our imaging centers instead of they're having to do an ER visit Friday night to get those same exams done, where you'll have the ER charges and an exorbitant fee for the same exam. So those are the market forces I see happening right now.
And then, Dr. Dickerson, I know we hear you all at Green Imaging talk a good bit about community health, and that means different things to different people. So can you break that terminology down for us?
Yeah, I really think it does mean different things to different people, and each community is so different. We were talking about this at the FMMA level with Matt Orr yesterday evening, and a community like Boston, where it's so hospital dominant and exams are so expensive, people really are willing to drive a lot of times to get something done affordably, and it's just an entirely different place than it's Houston, where I have 50 imaging centers and they all do everything, and I've got tremendous quality. Every community is different, and every community is a different size. We were talking about this with our CRM and how we classify communities when we're doing a build out for a network. Sometimes, in Texas, Houston has several different communities, I would argue. And then the state of Oregon, maybe two, Portland and the rest of Oregon. But, you really have to look at it very individually. You have to look at where are people consuming healthcare right now? Are they already commuting for healthcare? Are they used to going somewhere else for healthcare? Or are they used to only consuming it in their community? And then I think there have to be incentives. It's like James Frank, who's on the Legislative Health Committee for the Texas State House. And, he told his employees, he was in Wichita Falls, Texas. And he said, we're hospital dominant. We're getting killed. Your paychecks are getting impacted. We're going to start consuming healthcare differently. That means you may have to drive a little way, but every dollar we save is not going in my pocket. It's going in your pocket, and other benefits and improved wages. And I really loved that.
And of course, right now we are in the thick of renewal season, and you all have seen a tremendous uptick in interest in green imaging, in particular, in the cost of imaging. Can you talk a little bit about some of the questions you're getting or what you're seeing in the marketplace as it relates to those brokers coming to you and employers?
Yeah, we're seeing larger and larger, a lot of upstaging or upscale movement to larger and larger employers. And I think it's not always about price. I think it's harder and harder to access care. And one of the complaints that I'm hearing is that the employers are spending as much money on lost wages with employees trying to navigate the broken healthcare system and the time away from work as they are on the healthcare itself. And so I think, the access that we provide and the weight that we and other navigators take off the shoulders of employers to get them to the right place is tremendously valued in that place. The other trend that I'm seeing right now is everybody's talking about getting rid of their HSA plans, but a lot of them still have HSA plans. And, that can be a barrier to first dollar coverage. And it's not just a barrier to first dollar coverage. It's friction. That's the bad part about it. Just friction in the consumption of care, what should be a smooth process. And so I'm seeing more and more opinions out there. I'm seeing more and more attorney opinions that this doesn't constitute a significant enough piece of care to fall under the first dollar coverage provisions. So, the IRS guidelines are loose enough that they feel like that falls under that. When it's ordered by a DPC who's managing the overall screening and wellness of the patient, that should fall under screening. Just seeing a lot more flexibility, and certainly they're the tried and true ways, the W-2ing the income, the HRA backing up the denied claim, all kinds of ways to circumnavigate and make that smooth. And I'm seeing people being willing to adopt those alternative measures and going ahead in doing this, despite the fact there are HSA plans in place for now. They're all saying they're going to remove them in the next couple of years.
In an earlier episode we recently aired, there was a lot of discussion around prevention, and this episode actually had to do with colon cancer, but there was a talk about this resurgence and refocus on prevention. We know that for a couple of years after 2020, that was a problem. People weren't getting treatment the way they should. Are you all seeing more adherence to those preventive guidelines, which in turn might lead to more of the cancer screenings, more of the, having MRIs and the like and other imaging? What are you seeing in that space?
I think there are a lot of questions out there now. Should I be getting tests like Grail? Should I be getting a whole body MRI? One of the best responses to the whole body MRI I saw was from a physician, and it was actually a longevity physician, who said, look, if you go to whole body MRI from our existing means of screening for cancer, you are moving from the tiny millimeter stage at diagnosis with mammography now and with colonoscopy to the centimeter stage with whole body MRI. Why would we go backward? And I think whole body MRI has some utility for certain disease states and for certain people with significant risk factors. But I agree with her that we've got to continue the existing screening. The other place that, and where I would move into kind of the what's coming next, what I see in the AI world is we can now run a CT scan of a body part, the chest or abdomen or pelvis, as long as we have 3 vertebral levels, and get a quantitative bone density that's even better than a DEXA scan. And so I can run that off the same exam for a fraction of the cost of a full DEXA and for no additional radiation. I can also run a calcium score CT off any chest CT. I can run a calcium score, which is the very best predictor of cardiovascular risk. It's the best test we have for that. I can run that at a tiny additional fee. And I can also run cardiac chamber size, which is kind of a screening echocardiogram. So I'm seeing some really exciting things emerge in that space.
Thank you for listening to this episode of the Granite List.Live. Access our entire library by visiting your favorite podcast venue or subscribe on our site, thegranitelist.live.